Happy Thanksgiving. Let's talk about COPD exacerbations. Yo, I messed up with my lecture schedule. Shout out to all the docs on my team. Sorry about this. We're actually going to be talking about COPD exacerbations 2020. COPD flare-ups, acute exacerbations of COPD, emphysema flare-ups of chronic bronchitis, whatever you're going to call these things. This is when a patient who has COPD has a flare-up. Now, for my docs who are participating in Operation Odyssey, if you watch this video and do the little quiz, just let me know and I'll get you an achievement ribbon for it. For everybody else, if you want to follow along, fire up your up-to-date so you can get CME credit. This article is Management of Exacerbations of Chronic Obstructive Pulmonary Disease. I'll do a little bit of editorial kind of review of this article, a little bit of abstraction, and try to dwindle this 27-page article down to exactly what you need in your practice. And yo, this video is not really for patients. If you're a patient watching this, shout out to you for taking a proactive stance and learning about your illness, but this may not be for you, yo. This is for like doctors, residents, medical students. I mean, I can't keep you from watching it, but just realize this may be a little bit more confusing. There's probably some better like general topics that you could find out there. COPD exacerbation 2020. The Global Initiative for Chronic Obstructive Lung Disease, which is abbreviated GOLD for some nonsense reason. It should be abbreviated GICOLD. GICOLD, but anyway, GOLD defines an exacerbation of COPD as an acute event characterized by a worsening of the patient's respiratory symptoms that is beyond normal day-to-day variations and leads to a change in medication. This generally includes an acute change in one or more of the following three cardinal symptoms. So the cough either changes in severity or frequency. The sputum production increases in volume or changes color. And the dyspnea increases. So these are the three categories. So let's talk about this. So there is no like diagnostic test for a COPD exacerbation. Yo, it's a clinical diagnosis. You're not going to look at them and say, if your FEV 1% predicted has fallen this much, and if this, there's not like a metric, right? And so you're looking for three different things, of which one of them has changed. The cough becomes more severe and more frequent. So you got coughing, that's the first one, right? The second one is the sputum. It becomes, there's more of it, or it changes in character. Usually patients will say it got a lot thicker, or it got brown, or it changed color, or something like that, right? So you've got your cough variable, you've got your sputum variable, and the third one is real easy. They get more short of breath, right? So I like this diagnosis, because I'm like a hot rod mechanic, I'm not real cerebral. So this is a diagnosis where the patient looks at you and they say, my emphysema flare is flared up, right? Like the patient tells you what the diagnosis is. And they know, they don't have to like read up to date to know that those are the symptoms that are going to worsen. Okay. Now, risk factors for exacerbation. By the way, this is a great article. If you don't have up to date, you need to get up to date. So the risk of developing exacerbation of COPD correlates with age, cough, how long they've had COPD, have they had antibiotic therapy in the past, have they had a COPD-related hospitalization in the previous year, right? So 2 exacerbations or 1 that led to hospitalization is a big thing. Chronic mucus production, peripheral blood eosinophil count of greater than 0.34 times 10 to the 9th. So you're not going to use that to diagnose this. You're not going to say, oh, let's check your blood and see what your eosinophil count is. That's not going to happen. Theophylline therapy and having comorbidities, right? CHF, diabetes mellitus. CHF can be very, very perplexing because it can be exceedingly hard to differentiate a COPD exacerbation from a CHF exacerbation. No kidding. Like it can be very hard. It can be tough to tell. And you would think that it, if you, on paper it looks easier, but it can get kind of perplexing, especially if it's kind of a milder presentation. But the single best predictor of exacerbation is history of previous exacerbations. That is going to overtake everything. Every single risk factor a patient has is the history of exacerbations that is most important. The number of exacerbations in the previous 12 months is stratified. A history of 0 or 1 suggests a low future risk of exacerbation. So another way to like trick your memory into thinking this is everybody gets a free exacerbation a year. Now, if somebody had an exacerbation, was on a ventilator for 3 weeks, I think that makes them high risk. But in general, people get like 1 flare-up a year, right? But 2 or more suggest a high future risk. So this is kind of like a predictor. And the full article contains a whole lot more detail than this. I do encourage you to read a full article. I'm just trying to I'm trying to abstract this into actually what you need to go out there and see patients, right? Without all the other stuff. But it's an interesting article. It's a great article. Shout out to whoever wrote this. A lot better than the previous one, I feel like. Okay. GERD may be a risk factor for COPD, right? The whole extralaryngeal aspiration or whatever they call it with GERD, that may actually make you at higher risk. But therapy for GERD doesn't reduce the risk of exacerbation. So yeah, it may be a risk factor, but treating it doesn't make it any better. Pulmonary hypertension. So secondary pulmonary hypertension may be an additional risk factor for COPD exacerbations. How many patients with COPD have pulmonary hypertension? A lot. How many of them have it diagnosed? Not as many. Okay, triggers. Now, this is something you may want to remember. This may show up on the quiz. Respiratory infections are estimated to trigger approximately 70% of chronic COPD exacerbations. Cricket, did you hear that? 7 out of 10 COPD exacerbations are triggered by viral or bacterial respiratory infections. The remaining 30% are due to environmental pollution, pulmonary embolism, or have an unknown etiology. I had a patient that had COPD and was very sensitive to one kind of like something in the chicken feed. And so he drove a big rig, and occasionally he would haul like chicken feed, I guess, because, Arkansas, we produce like all the chickens in the world. Anyway, but if he breathed that in, boom, COPD exacerbation. Some patients will know their triggers that actually can kind of provoke this. Now, here's the thing. Environmental pollution or pulmonary embolism. There is so much pulmonary embolism involved in COPD. It's kind of a chicken or the egg thing. They don't know how many people with COPD have a pulmonary embolism that is identified. We're going to get more and more into this, but always think about pulmonary embolism. Just in the back of your mind, think about that. Okay. Let's go a little bit further into that. The relationship between COPD exacerbation and pulmonary embolism was illustrated by a meta-analysis. I love meta-analysis. That's like my favorite thing. You get older. I'm old, I used to tear up the streets and run around all the time. But you get old, you start getting excited about things like meta-analysis. A meta-analysis of 5 observational studies this is kind of like a meta-analysis. It's kind of like cleanest dirty shirt, but anyway. A meta-analysis of 5 observational studies. Among the 550 patients having a COPD exacerbation, the prevalence of pulmonary embolism was 20%. 20%. 1 in 5. The prevalence was even higher, if you can believe that, 25% among those hospitalized. So if patients hospitalized with COPD exacerbation, a fourth of them had a pulmonary embolus. Now, there were some limitations to the meta-analysis, blah, blah, blah. Okay, let's move on to clinical manifestations. Always think about PE. So the clinical manifestations of exacerbations of COPD range from a very mild increase in dyspnea or productive cough to respiratory failure due to acute respiratory acidosis or hypoxemia. So physical findings associated with an exacerbation of COPD, and y'all know this, wheezing, tachypnea, difficulty speaking. Boy, if you get somebody in there and they say, COPD has flared up, and they're not making full sentences, that is a ominous kind of thing, okay? That means they don't have the cardiopulmonary reserve to talk. Not good. Difficulty speaking, use of accessory respiratory muscles and paradoxical chest wall abdominal movements, asynchronous chest abdominal wall motion. If present, decreased mental status could reflect hypercapnia or hypoxemia, and asterixis could indicate increased hypercapnia. So, let's talk about this a little bit. If there are patients that get goofy when they're hypercapnic, like the old term for that was CO2 narcosis. Do you know the new term for that? If you do, leave it in the comments. There may be a new term, there may not be. I still call it PCP pneumonia, and that's not right. Hey, take a minute. If you like these lectures, click like and click subscribe. New channel. I don't know if we're going to keep doing these medical lectures, but if people get into it and it helps them, and when they're driving to work, they plug the phone in the car and listen to it, then I'll keep posting them, online. Not just for my docs, but for the others too. Okay. The goals of the initial evaluation of a patient with suspected exacerbation of COPD are to confirm the diagnosis, identify the cause when possible, oftentimes it is not, assess the severity. The choice of specific tests is guided by the severity of the exacerbations. That makes sense. We're not going to go full blast on a patient who has very mild exacerbations. For patients with the mild exacerbations, they're not really short of breath at rest. They don't have any respiratory distress, and they can still perform their ADLs. Who do not require emergency department treatment, the evaluation may be limited to clinical assessment and possibly pulse ox. So let's talk about this real quick. When somebody is having an emphysema flare, these are common things. You know what I mean? This is like a person with panic disorder having an anxiety attack. So, for example, let just follow me on this, okay? So you're treating a patient who has panic disorder, right? And this patient comes in and you say, did you have any panic attacks since last? And they said, yes, one time I was, triggered by being out in the grocery store, had a panic attack. What happened? Well, my heart started racing and I got short of breath. You would never say, oh my God, your heart started racing. You got short of breath. Let's do an echo and a Holter monitor and an EKG and electrolytes and check your magnesium. No, fam, you would not do that. And the reason you wouldn't do it is you would say, well, this is kind of an expected part of this disease, and it's probably not going to be harmful. So when you have a patient who is clinically mild, you don't even have to x-ray them, right? You literally just check their pulse ox, listen to their lungs, talk to them. The patient is your best resource here. So you don't have to go overboard. And these patients get a whole lot of over-testing, And I get it. Like when I was new in practice, I'd be like, what are your peripheral eosinophils? And that's me pushing my glasses up when I'm talking about eosinophils. Okay. For patients who require emergency room care, the evaluation should include the following. So if they're going to the ED, you probably think they're pretty sick. So they need pulse ox, they need x-ray to exclude a pneumonia, a pneumothorax, pulmonary edema, or pleural effusion. This is very, very important. I had a patient one time that I thought was having a COPD exacerbation, had a pneumothorax. We identified it because we x-rayed because the person was sick. It was very, very, very short of breath. So many patients have undiagnosed CHF, or you may initially diagnose CHF in a patient with COPD and you think it's a COPD exacerbation. Actually, they're in decompensated congestive heart failure. It's very important. Are you going to see a pulmonary embolus on a chest x-ray? No, probably not. 3 in the history of the world have been seen on a chest x-ray. Laboratory study. And this is the weird thing about med school. I've never understood this about med school. They show the most severe, and shout out to medical school, UAMS, that's where I went, Arkansas, Little Rock. Lived on a boat, awesome time. They always show like the most severe examples. So like they'll show examples of chest x-rays where like even like a primary care doc can like see a pulmonary embolus, but it usually doesn't look like that. So I don't know, Okay. Laboratory studies include CBC differential, serum electrolytes. Of course, if they have a pneumonia, you might do a, if they have a pneumonia and they got terrible COPD, that's when you might consider doing a blood culture. You might do a urine streptococcal antigen, urine Legionella. That may change your tact, but if you kind of exclude pneumonia, they need a CBC and electrolytes basically. ABGs, okay? If they're sick enough to go to the hospital, they're probably sick enough to get an ABG. Additional tests are obtained depending on the clinical evaluation of the patient. Often, EKG cardiac troponins are done to identify myocardial ischemia, BNP to assess for heart failure. So BNP can be elevated in pulmonary cases. So in cases of lung disease, BNP can be elevated. So it's not like a slam dunk, but boy, that BNP can give you a clue if it's heart failure. and a D dimer to assess for thromboembolic disease. So how accurate are D dimers? Not very, but this can be kind of tough to ferret out. So nothing wrong with that. I don't think I would routinely start doing BNPs and D dimers on people unless you kind of thought that. So sputum, gram stain, and culture. Sputum, gram stain, and culture are kind of useless in COPD exacerbations. Somebody's got that thick sputum, you might think, oh, that's fantastic, but they don't have pneumonia. There's not much utility in it. While not necessary in most patients, evaluation for possible respiratory virus infection, including influenza, and this is weird because this is Thanksgiving 2020, and I don't think that it even has the word coronavirus in here. But obviously, COVID-19 can provoke a pretty significant, response. Flu can provoke all these respiratory viruses. Some people use like film arrays, like PCR diagnostic panels that have a whole bunch of viruses. But remember, 70% are caused by some sort of infection. Okay, differential diagnosis. Patients with COPD who present to the hospital with acute worsening of dyspnea should be evaluated for potential alternative diagnoses. And this is what we talked about. Pneumothorax, pneumonia, pulmonary thromboembolism, and heart failure are kind of your big ones. Now, this is interesting. I highlighted this for this specific reason. There was a small autopsy study of 43 patients with COPD who died within 24 hours of being admitted to the hospital. And they died within 24 hours of being admitted with a COPD exacerbation. The primary causes of death were heart failure in 37%, pneumonia in 28%, pulmonary embolus in 21%, and just dying from COPD in 14%. So this shows that you've got to, this sort of illustration shows that, only 14% of these COPD deaths actually died from COPD, and the rest of them, died from something else. Okay, triage to home or hospital. If the exacerbation is life-threatening or if they look like they need ventilatory support, you got to admit them to the ICU, right? So if this patient looks like, these patients are going to be ICU patients if they have respiratory failure. The good news is 4 out of 5 COPD exacerbations can be managed at home. So that's good news. Other criteria that may lead to a decision to hospitalize. So if they're failing outpatient treatment, do a short follow-up. If somebody's on the fence, do a 48-hour follow-up with them, 24-hour follow-up. Have them come back in your clinic and see how they're doing. New signs, increased intensity of symptoms. Y'all know this. There's no reason for me to list these out. But here we go. Frailty and insufficient home support, okay? Frailty and insufficient home support. Figure out what's going on in your patients' lives. I'm not saying that as a doctor you have to be a social worker, but just figure out, what's going on in these people's lives. If they don't have any support at home, then put them in the hospital. I know that everybody hates that, and there is risk to going in the hospital, but if this person is homeless or in some kind of living situation that's kind of, bad, just treat the whole patient, I know we swim in a world where medicine is nothing more than, this weird sort of para-governmental health insurance industrial complex where everything is just an arms race of rules and things like that. But you got to treat the patient, Home management of COPD exacerbations. Home management of COPD exacerbations includes bronchodilator therapy and initiation of a course of oral glucocorticoids and then maybe oral antibiotics. So you're basically going to do more aggressive bronchodilation. You're going to give all of them oral glucocorticoids, and you're going to see if they need antibiotics. And we're going to talk about how you do that. So short-acting beta agonist, albuterol or levoalbuterol, are the mainstay of therapy for acute exacerbation of COPD. They're rapid. Remember, at normal doses, beta agonists have submaximal bronchodilation. So if you go above the patient's normal dose of beta agonists, they will have above normal bronchodilation, which will be beneficial to them. For patients being managed at home, these medications are usually administered by a metered dose inhaler with a spacer device. Patients who already have a nebulizer at home frequently find that administration of beta-adrenergic agonists via nebulizer is helpful. However, most studies, now this is important, okay? Most studies have not supported a greater effect from nebulizer treatments over properly administered MDI metered dose inhaler albuterol. So I've had numerous COPD patients over the years that have said, well, I need a nebulizer for when I have a flare-up. Nebulizers do not work any better than MDIs, but they seem like they should. You know why? Because it's an event. If I do that, that's not an event. But if I have a machine that's spraying smoke into the atmosphere and everything, it seems like this is some sort of seance that's going to get rid of my COPD. It doesn't work any better than MDI. You know, and these things have cost to patients, and it somehow makes the patient feel like the MDI is less effective. So now they feel like they walk around their life getting suboptimal treatment. Then they want to do nebulizations all the time. So, okay, let's talk about anticholinergic agents, short-acting muscarinic antagonists. Ipratropium, an inhaled short-acting anticholinergic agent, or a SAMA, S-A-M-A, short-acting muscarinic antagonist, is an effective bronchodilator for exacerbations of COPD and is often used in combination with inhaled short-acting beta agonists like albuterol. So here's what you need to know. You could use ipratropium for a COPD exacerbation, and you can use it along with albuterol. These things have an additive and synergistic effect. Albuterol plus ipratropium will bronchodilate more than either one of these agents alone, okay? It's not redundant therapy, so this is important. 0 times, did anybody ever say this in med school, or maybe I was just, absent, or I didn't have the best attendance, whatever. Okay. The evidence, we already talked about that. Oral glucocorticoid therapy. Systemic glucocorticoid therapy appears to have a small but beneficial effect in outpatients with exacerbations of COPD. We suggest, now this is dudes suggesting this, right? This is human beings suggesting this based on, kind of inductive reasoning and the evidence that they have. 40 milligrams of prednisone for 5 days. Write it down and remember it. You're not going to come up with anything better, and neither am I. 40 milligrams a day for 5 days, okay? Now, there was a randomized trial of 147 patients. Patients who received prednisone were less likely to return to the ED or to their doctor with increasing dyspnea within 30 days. So it does reduce those repeat visits. The efficacy of inhaled glucocorticoids has not been studied in randomized trials. They should not be used as a substitute of systemic glucocorticoid therapy. Okay, here's the take-home message. So kids with asthma had asthma action plans that said double your inhaled corticosteroid. In COPD, inhaled corticosteroids are used for COPD. Watch the last lecture. Maybe somebody can tell me how to put the little thing where I could point in the corner and you click on it. But we talked about this in the last lecture. Even if you're using it for COPD, they don't have a role in COPD exacerbations. Like, you're not going to add an inhaled corticosteroid if a patient has a COPD exacerbation. You're going to give them oral glucocorticoids. Prednisone, 40 milligrams, 5 days. Write it down. Next year we'll make another video. If something changes, I'll let you know. Okay. Antibiotics. Now, this is another kind of gray nebulous area. To try to maximize the benefit of antibiotic therapy, many clinical practice guidelines recommend antibiotic therapy only for those patients who are most likely to have bacterial infection. Well, they don't raise their hands, right? They don't say, I'm the one with bacteria. So the GOLD guidelines recommend antibiotics for moderately or severely ill patients with COPD exacerbations who have increased cough and sputum purulence. Now this is the up-to-date editors, we recommend antibiotics in outpatients with moderate or severe exacerbation, which is defined as having at least 2 of the 3 symptoms: increased dyspnea, increased sputum volume, or increased sputum purulence. Okay? Now, this is kind of weird because, I'm thinking back. I'm a clinical informaticist, CMIO, right? I apply technology now. That's one of the reasons I do like virtual lectures, stuff like that. So thinking back to when I saw 4,500 patients a year, I don't know how many, they all had increased shortness of breath, all of them. 100% of them with COPD exacerbations had increased shortness of breath. And if you look at increased sputum volume or increased sputum purulence, it appears to me that if I go by 2 of those 3 things, shortness of breath, increased sputum volume, or increased sputum purulence, I would have given antibiotics to 95% of people with COPD exacerbations. But this is what the editors say. Now, when we use an antibiotic, just FYI, we're going to use a macrolide. If Pseudomonas is possible, we're going to use augmentin or fluoroquinolone. So we're either going to use, macrolide monotherapy. If we think they have Pseudomonas, we can use augmentin or we can use a respiratory quinolone. Okay, so let's talk about hospital management of COPD. In-hospital monitoring includes frequent assessment of respiratory status, in-hospital monitoring typically includes frequent assessment of respiratory status, respiratory rate, effort, wheezing, pulse ox, heart rate, rhythm. Also, fluid status, ABG, is performed to look for respiratory acidosis or to monitor known hypercapnia. Supplemental oxygen is a critical component of acute therapy. Now, this is the old thing where people say, well, don't give them too much oxygen because that could worsen their hypercapnia. So what you want to do is the target for oxygen, just remember this number, just file it away and go away with it. The target of oxygen is 88 to 92%. So you want 88 to 92% while you're giving that supplemental oxygen. The oxygen tension, the PaO2, you want 60 to 70 millimeters of mercury. And there have been two small randomized trials where that 88 to 92% pulse ox actually resulted in lower mortality. So let's talk about devices we're going to use for a COPD exacerbation. So Venturi Masks are the preferred means of oxygen delivery. They give you a very precise delivered fraction of FiO2. And they can do 24, 28, 31, 35, 40, or 60%. You can use a nasal cannula. And a nasal cannula at 6 liters a minute has about an FiO2 of 40%. A face mask can bring the FiO2 up to 55%. A non-rebreather with reservoirs and one-way valves and Holly 750 double pumper can actually get you up to 90%. And high-flow nasal cannula, the indications for that are kind of unclear. So let's talk a little bit about giving oxygen. A high FiO2 is usually not required to correct hypoxemia. Usually you can correct hypoxemia with a relatively low FiO2, okay? And this is why you see a lot of people with COPD exacerbations managed with nasal cannula and things like that, and they don't have non-rebreathers on and stuff. Now this is important, inability to correct hypoxemia with a relatively low FiO2 should prompt consideration of pulmonary emboli, ARDS, pulmonary edema, or severe pneumonia. So here's the deal. If they're requiring a lot of oxygen, you need to think this may be something other than COPD, because the nature of a COPD exacerbation is that they don't require a lot of oxygen. Hypercapnia is usually well tolerated in patients whose arterial CO2 is chronically elevated, but if they get hypercapnia to the point that they're getting goofy, that they're not making sense, that their mental status is depressed, they may be progressing towards mechanical ventilation. Now, usually when they're in the hospital, we do give albuterol. And you might say, well, why are you saying that? You just said use MDI earlier. Because these people are sick, and it may be difficult for them to use a proper MDI technique. You're basically putting somebody in the hospital with something that could be fatal, so you don't need to rely on them to do that. Now, realize that it is okay to do updrafts. Continuously nebulized beta agonists have not been shown to confer an advantage in COPD. Get used in asthma a lot, but in COPD they don't confer an advantage. We concur with the British Thoracic Society guidelines that suggest using air rather than oxygen-driven bronchodilator nebulization or limiting oxygen-driven treatments to 6 minutes. So when you're giving them an updraft, use a machine that does it with air, not with oxygen. Because if they're doing an updraft with oxygen, you're giving them more oxygen. So this may affect that pulse ox and drive it up above 92, and we want it in that sweet spot of 88 to 92. So if you have to use oxygen, only 6 minutes. Where did that come from? I have no idea. It's like 6 feet with COVID, like 2 weeks into COVID, 6 feet. Okay, anticholinergic agents. The evidence is conflicting regarding the use of SAMA in combination with short-acting beta-adrenergic agonists to treat exacerbations of COPD in the hospital. Okay, so if they're in the hospital, We're not sure how much benefit the Ipratropium and Albuterol and the synergy. We're not sure how much that is. I don't know why. Maybe because we're giving them more beta agonists. They're getting more of a maximal bronchodilation, but it's typically done. There's nothing wrong with doing it. Okay. Systemic glucocorticoids. They reduce, here was a study, they reduced the risk of treatment failure by over 50%. Now, I'm going to basically take 3 pages and turn it into 3 sentences. Oral glucocorticoids, like if you give somebody prednisone pills, that reaches a peak in their bloodstream in an hour. There is really no reason to give anything other than oral prednisone, right? Like you don't have to give parenteral steroids to a patient with a COPD exacerbation. Moderate doses appear to be better than high doses, maybe better, or at least as effective as high doses. We don't know the optimal duration of therapy. Up-to-date article says a range of 5 to 14 days appears to be reasonable, but when it's been studied, the long courses don't really work any better than the short courses. You don't have to, let me just save you some pain here. You don't have to taper a steroid as long as your course is under 3 weeks. Like you don't have to taper a steroid that's been going for 10 days. That's not a thing. Okay. Supportive care. Everybody in the hospital needs to get smoking cessation while they're in their thromboprophylaxis and nutritional support. There is an insanely high mortality associated after hospitalization with a COPD exacerbation. Think about palliative care if these patients are really sick. Okay. Now let's talk about what does not work. What doesn't work? What are treatments without documented benefits? Well, mucoactive agents like N-acetylcysteine don't work for COPD exacerbations. And I'm just going to throw this out there like Mucinex. You know, everybody takes Mucinex. I don't think it does anything. Like you don't have to give patients Mucinex. Like I don't think there's any evidence that does anything for anybody's COPD. All it does is lighten the old wallet a little bit. Big Mucinex is the only one who benefits from that. Methylxanthines. What's a methylxanthine? Who knows? They're talking about Theophylline. Theophylline is second-line therapy for exacerbations of COPD. I've never used it for a patient with a COPD exacerbation. I did have one patient in my entire career practicing medicine thus far who benefited from Theophylline for COPD management, but not for exacerbation. Nebulized magnesium, that's just, chest physiotherapy, these are the things that shake you and beat you around. It's nonsense. This chest physiotherapy doesn't do anything. It's just, boy, that's the smoke and mirror. That's the dry needling and cupping of COPD exacerbation. Okay, mechanical ventilation. Always be aware of what doesn't work. There's so much. People constantly get ripped off. And you hear me rail about expensive drugs that don't work any better than cheap drugs, but so much stuff is nonsense. Okay, mechanical ventilation. Ventilatory support man, I'm just knocking this one out of the park, guys. Ventilatory support may be needed for patients with more severe exacerbations of COPD, such as severe dyspnea with clinical signs of respiratory muscle fatigue, increased work of breathing, or both, and also respiratory acidosis. So, arterial pH less than 7.35 and a PaCO2 greater than 45 are good things to look for if a patient needs mechanical ventilation. I can remember working in the ER one night, and a lady came in with the COPD exacerbation, and she literally was exhausted. I mean, she was exhausted to the point of failure. It'd be like if I went out and tried to run a marathon right now. I mean, she was like about to literally die because there is a limited cardiopulmonary reserve to begin with from a standpoint of exercise tolerance, and it takes a lot of effort to work these muscles, okay? So, non-invasive ventilation is the preferred method of ventilatory support in many patients with the COPD exacerbation. So what you want to use is non-invasive ventilation. We don't know exactly the best settings to start somebody out on. Usually we do a triggered mode, inspiratory pressure of 8 to 12 centimeters of water, and expiratory pressure of 3 to 5. So 8 to 12 in, 3 to 5 out, and usually a triggered mode. And it has kind of a backup rate associated with it. Now, invasive ventilation should be administered when patients fail non-invasive ventilation. So let's talk about prognosis here. In-hospital mortality, 3 to 9%. 14% of patients admitted for a COPD exacerbation will die within 3 months. Okay? Now, this is wild. If the patient has a PaCO2 of 50 millimeters of mercury or more, the 12-month mortality is 43%. So if somebody gets into, and we had a terrible mnemonic for this back in the old days. I'm not even going to, it's like dishonorable. I'm not even going to say it. But basically, if the PaCO2 gets to 50 millimeters of mercury, they got about 50% chance they're going to die in the upcoming year. That's kind of a mental trick that you can remember it. Patients hospitalized for COPD exacerbation who have Pseudomonas in the sputum have a higher risk of mortality at 3 years. That makes sense to me. They're usually sicker, more comorbidities. Prevention. Several measures have been shown to reduce COPD exacerbations. Smoking cessation, pulmonary rehab. Pulmonary rehab works best, I think, when it's done, kind of soon after. Increased physical activity, proper use of medications, and vaccination against flu and pneumovax, and then here in a couple weeks against coronavirus too. Hoping, do a little macho man climbing on the top rope there. Okay. Pulmonary rehab and a systematic review. Boy, I hope I'm right. I love it when I say something off the cuff and then boom, here's something that supports it. Let's see if I'm right. In a systematic review, participation in pulmonary rehab immediately after hospitalization reduced rehospitalization. There you go. Good job, Coltrane. All right. Action plans. So we don't know. Like you see asthma action plans. There's no such thing as a COPD action plan. I'm not saying nobody's done one. I'm just saying there's not really a COPD action plan. Prophylactic antibiotics. Boy, this is, okay, I've done it. You need to read this topic. And I don't know, I'm trying to do kind of broad things that help people. If you have a patient that has, intractable, horrible, frequent COPD exacerbations, read the up-to-date article. It's called Management of Infection and Exacerbations of COPD, Prophylactic Macrolides. The name of the article is Management of Infection and Exacerbations of COPD. Read the prophylactic antibiotics. It's prophylactic antibiotics. It's kind of some confusing stuff. There's a few up-to-date articles that I would read at the point of care with a patient. Like when I'm in the room with a patient, I will read it. Dermatomyositis. I'm going to read it. Okay, this doesn't make any sense to me. Potential benefit of beta blockers. Preliminary observational data suggests that therapy with selective beta blockers for comorbid cardiovascular disease is associated with a reduction in COPD exacerbations. I don't know why that is. Vitamin D, conflicting results of vitamin D supplementation for prevention of COPD exacerbations. I know that everybody in America takes vitamin D now because of Joe Rogan, but we don't know if that helps too much. Ineffective interventions. Statins don't work. They don't hurt anything. It may help other things, but they don't work for COPD exacerbations. All right, click like, click subscribe. If you like these lectures on YouTube, please leave me a comment because otherwise I won't know and I'm just going to quit doing them. But for my team, y'all make sure, take the quiz, send me little things stating that you took the quiz. Hope everybody has a happy Thanksgiving and thanks for watching.